So when we do that, it has to be system-centric approach. So when I said system-centric approach, any hospital or a unit should run as a system-centric, as a system. When I was involved in the construction and operationalization of the regional advanced pediatric center, there was a period of 1 year where the building was handed over and subsequently the function was not going on. It was not operationalized. So some of my colleagues came and said, look, Baliga, till you're there, the hospital will run. And after that, it's going to go to docs. It's not going to function. But I was quite confident because I made it system-centric. I put the systems in place. It was not individual. It was not dependent on one individual to run. So when we look at the neonatal unit, if you want to get the maximum, you need to make it system-centric, not individual-centric. The unit should not depend on the individual. So National Health Service defines the medical leadership competency framework. In the sense, what are the competencies of a leader? So the first is he should be able to set the direction, should be demonstrating personal qualities, his ability to work with others, managing services and improving services. Directional skills means making goals and plans, solving problems as they arise, and he should be guiding the organization towards the future. That means the change. This is exactly what I meant earlier, that leadership means to bringing about a change. Of course, we need to learn. We need to be good leaders, but how will the subordinates or how will the other people remember? Maya Angelou was an American poet and singer. She said, I've learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel. So maybe this is a statement which is very, very applicable in day-to-day life in the NICU. How nicely we make the people, the nurses, the IRs, the attenders, technicians, comfortable, how we make them feel good, motivate them is the one which decides the outcome. And that again depends on the personal qualities of the leader, developing self-awareness, and most important is intrapersonal management. If there's a good intrapersonal management, then there will be a better, very, very acceptable interpersonal management. And this personality is like CME is a continued process of development. As we grow in the profession, we accumulate more and more wisdom. We become less and less aggressive. So we also need to act with integrity and we need to be empathetic. Many a times as teacher, we teach empathy we tell the students to be empathetic. Be empathetic. You should show empathy to the patients. But it begins with when we show empathy to our students, to people who work with us. So a good leader is empathetic to his entire team. And to manage good intrapersonal management depends on balancing life expectations. So that, I would just take you through this Ikigai Japanese model, how they are extremely happy. So it depends on what you are good at, what you love, what the world needs, and what you can be paid for. And balancing between passion, mission, profession, and vocation. So that's how we need to differentiate between need and greed. In spite of all these things, we at times we feel low, we come across situations where we are disgusted, low morale. Definitely at that time, do look at the survivors and their smile. Parental gratitude for surviving NICU graduates. So it's a good idea to keep a track of NICU graduates. This type of leadership depends on directive, participative, and delegative. Directive is known as autocratic, bossing over. Participative referred to as inclusive, and delegative is also where you practice of letting people to do as they wish, and very, very accommodative approach. And there's no right or wrong kind of leadership. Many of the best leaders employ combinations of giving suit. So Eleanor Roosevelt, American political figure, said, to handle yourself, use your head. To handle other, you use your heart. That's how you can be empathetic to your teammates. And that brings us to making decision, which is done every second minute by medical professionals. And it's a cycle which is required for diagnosis, management, communication, health system, HR management, protocol, policies, and so on. But it's very important to remember we have only one choice: make the right decision at the right time. Right decision at the wrong time has same morbidity as a wrong decision at the wrong time. So presently, what the method of making decision is case based. We are depending on the case, and we have learned it by our by neonatologists on behalf of the parents. We learn from our seniors, from the fellow colleagues. It's something called legacy transfer. But a better model is shared decision between parents and neonatologists. And it's a change that is required with generation change. But the future is decision using big data and artificial intelligence. So case-based model, it evolved from being opinion-based. Making opinion should have sound scientific evidence. And we need to be judging rather than being judgmental. Judgmental is the one which takes us to the brink of medico-legal cases. It's an everyday demand, but it's pretty difficult to keep up with the pace. Nevertheless, we need to understand difference. There are multiple factors. There are scientific factors, there are non-scientific factors which influence a clinical, case-based clinical model. Disease, prognosis, response to treatment, and there are unknown factors. Whatever we do, sometimes it goes beyond control. But most difficult to understand are the ghost factors, where out of blue, when we have taken the decision, communicated with the patient, but suddenly there is a change. So we need to keep in mind family chemistry, myths and beliefs, economic status of the parents before we take any major decisions. So everyone wants to be in the ease of case-based decision cycle. So the concept of preparedness ahead of the disease. We should be always ahead of the disease and give anticipatory information to the patients. And we need to give futuristic plan of action give the alternatives, and then take the decision, which is shared decision. Collecting information of the neonates in the unit before starting off to the unit or to the hospital, and having analysis and mentally preparing oneself will go a long way to get into that zone of comfort. Understanding models of decision will also help. Activity passivity. It's an authoritarian approach. Guidance cooperation is informed treatment. Mutual participation is a shared responsibility. To give example, activity passivity is the amount of IV fluids, vasopressor, you have to decide routine which antibiotic to be given. You do that as routinely and inform, yes, this is what is done. This is activity passivity. Guidance cooperation is when you want to do ultrasound, IEM test, put a central line, you explain that it is required and the patient agrees and you carry out this procedure. This is a decision. Mutual participation is do no resuscitation, or when you have to ventilate or not to ventilate. Such are the situations, there's a mutual participation. And the guiding principles for that, such decisions are right to life, parental rights, ethical issues, and legal implications. Right to life is the belief that a being has the right and should not be killed by another entity, including the government. And I wanted to find out more about what is this right to life. And I found this statement by former Chief Justice P.N. Bhagawati is very, very apt. The neonate is a soul with a being, a nature and capacities of its own, who must be helped to find them to grow into maturity, into fullness, on physical and vital energy, and most breadth, depth, and height of its emotional and intellectual and spiritual being. Which is very, very true for us. Before we take the decision, we need to consider neonate as a soul. So just to summarize, getting into comfort zone is right decision at the right time, anticipatory information, working ahead of the disease or problem, establish and practice decision model, always take second opinions, offer options for treatment, and adapt shared decision models. What is this? Okay. So in spite of all this understanding and getting into all the aspects of decision making, but still we face difficult situations. So there are situations when neonatal palliative care, end of life support would come, but one should provide compassionate, family-centered care. Do not resuscitate and end of life support, end of life care. So Indian Academy of Pediatrics recently came out with this document. Anyone can read that, and it could be applicable to neonatal unit also. And activate after consensus with the healthcare team, including the nurses, get a consensus within the unit, involve other persons, give the choice to the family members, invite the family physician or prominent person, respect family members' choice. They can choose the member of treating team, make facts of the case available, including investigation. Unit in charge and treating doctor should be responsible and encouraged to ask questions and clear doubt. Summary of the discussion should be documented with signatures. Review it when unexpected improvement or request by next of the kin. Document again, and the whole document remains valid throughout the transport. That's not enough. I belong to baby boomers generation and had the privilege of being trained by traditionalists. But subsequently, new generations have come. We have generation Z, X, Y, and Z. So future is going to be IT based. So newer decision skills for preparing tomorrow is also required. So neonatal clinical pathway is one way. It's a clinical tool for standardization, delineates practice guidelines in the specific neonatal population, linked to health and economic outcomes. It's a multidisciplinary. All the people involved in neonatologists, nurses, physiotherapists, mental health people sit and validate the healthcare data, and it supports all the decision, incorporate quality management techniques. Best example is evidence-based clinical decision support at the point of care, up-to-date URL. Point of care is going to be bring about big difference in how we decide in the NICUs. Individual narrow focus decision support system is again a computer-based information system used to integrate clinical and patient information to provide support for decision making. And in future, it's going to be big data application and artificial intelligence. There's a global scope for application focused on building a cognitive system capable of self-learning and knowledge digestion directly from non-formalized text sources. And I would urge the younger generation to look at how they can associate with the IT people and maybe the IIT people. Look into this and how one could develop artificial intelligence and these systems for our country, because that's going to be a big way. And we have plenty of clinical material. So with that request to my younger generation, a big thank you for listening, and thanks Prashant Gowda and the team NNF for giving me this opportunity. Thank you.
So, fantastic. Thank you very much, sir. It's indeed pleasure to listen to you and get your experience. You have such a vast experience, and most of the doctors who have logged in today are all of your students itself, and they're all big fan of you. And thank you very much for enlightening us and guiding us. We will move on to the next topic. So the next topic, I request Aman, do not record this topic because it's a medical legal, so it can be medical legally problematic if you record. So this medical legal aspects in perinatology and neonatology will be done by none other than our beloved Dr. Kishore Kumar sir. He doesn't need any introduction. He is the chairman, founder of Cloud9 Group of Hospitals. He is a phenomenal professor in Indira Gandhi Institute of Child Health. Plus, he has got an Harvard University graduate in MBA.
And so far, we have heard Dr. Shantaram Baliga about the leadership and then decision making. Second is the baby who is dying or even died. Third, my job is to see how to prevent the problems after death. As we all know, we are seeing more of aggressive behavior of the parents and also the looting, which we see day in and out in a baby when he dies in an NICU or in a PSU. My job is to take you over the last 40-45 years since I've been in neonatology. My first neonatology started in Christian Medical College Hospital, Vellore. I was in charge of this I will classify as pre-NICU era. And now in Ramaya, I'll put it as post-NICU era. Pre-NICU era, the people are totally different. Society was different. Society used to put us very next to God. They always used to say, doctors are next to God. That was the status. We didn't have any problems in explaining to the parents about the death of a newborn baby. The spectrum of diseases, what you see, was a little different. used to see a lot of asphyxia and its complications, to see septicemias, you see hemolytic disease at a newborn. Used to do a lot of exchange transfusions. This is pre this this treatment of this particular Rh hemolytic disease in newborn. And next, we also used to see neonatal tetanus before we started giving antenatal TT. Very difficult. This particular thing was very easy for us to explain to the patient because most of the problems were with the patients and relatives. Next, I had a stint of work in Erode. I was sent to Erode to start a neonatal unit. They were interesting. They were very rich people I used to see. But the people the babies used to die of castrol administration. Again, it's very difficult. It was quite easy for us to explain to the patient because we are fault the baby has died. Now, third, I had a stint of work in St. John's Medical College. Again, this situation is almost the same. My last journey was in Ramaya Medical College, almost for 25 years, where we started neonatal unit. The post-NICU era was a little different. The spectrum of cases was totally different. We used to see a lot of newborn babies with septicemias and also premature babies with complications like hyaline membrane disease. And we started giving this Cervanta, and we are seeing necrotizing enterocolitis, and we also had retinopathy of prematurity. The spectrum was totally different. The baby used to survive long, and when the death occurs, it's always a problem. Why this change has occurred in the patient, in the society? I would like to give at least 3 different causes. One is the education. Over the 40 years, I see the education has improved, especially female literacy has improved. Second, there's easy access to the medical literatures. Parents know sometimes much better than what we know. Third is the capacity of the patients. The financial, they can also spend more. Spending capacity is improved. These 3 things have made us a little problematic when you are explaining a death of a newborn baby. Yes, I will start with the WHO, the state of health. When you talk about health, there are 4 important components of health. It's not just the physical. You have psychological, emotional, spiritual, and social health. When any of these things are lacking, you will be in trouble, especially when you are talking to these parents who lost their baby. Yes, now I'll take you to the actual ICU scenarios. One is a patient which brought with a background of ICU admissions or next to death or rebirth of a baby if the baby survives. Now I'll take you to the actual NICU scenario. Doctor meets the parents. Generally, the doctor in a NICU, they are cool, calm, confident, experienced, optimistic, and he meets highly strung, restless, whose mind is a cauldron of imaginative recipes. What does it mean? Imaginative recipes means, what I feel is, how long this baby will survive? Will this baby have chance of survival? Is he going to die? And what will be the cost of the treatment? All these things the patient or the parents will think of with an attitude of complete surrender to the doctor. What does it mean? In a in our local language, they always say that we have brought the child doctor to your hands. It's up to you to see what can be done to this baby. And we expect, and lastly they say, we expect the baby to come out of the NICU. Now the scenario of the involved doctor and the patient. There's an urgency to diagnose for a doctor or a neonatologist. So he is in a state of urgency to diagnose and start the treatment. That is his topmost priority. And for the patient, he is very eager to know the prognosis and nature of the illness. Is a burning question in the minds of the relatives. Usual questions generally asked is it serious, doctor? Very difficult question to answer at the time. Will he be all right? These are all the questions which you feel very difficult to answer at that stage. I would say that Caesar will give you some time. We will also have some time to see the baby, assess the baby, stabilize the baby, and ask for some investigations. Look into the investigation. We can say that what can be wrong with the baby. So buy some time when these questions are being asked to you. Now let me see the coping spectrum of the patients and the doctor. Doctor is generally strong with the skills because of the experience. He sees this type of patients day in and out. But under threatening conditions, he can fail because of the legal implications what Dr. Kishore has mentioned, violence, etc. In general, parents are poor with coping skills because they are inexperienced, but they got a lot of family support. At this juncture, I would like to mention that we must always use their family support when you are counseling these babies and these parents. Doctor builds the emotional bridge. He should give a regular feedback to the baby about the case. This is a very important thing. I am sure that every unit is practicing this. Around 11:30, 12 o'clock, after the rounds is over, everybody goes to the counseling room with a piece of paper and pen and with this battalion of a nurse who is in charge, plus his own people. And I would like to say at this juncture that spend some quality time. You may be very busy. My experience is many times we manage about 10, 15 babies in the NICU. We have to talk to all these people and it's already 11:30, 12 noon and we don't have much time to go for lunch and then the classes in the afternoon. So, but sick child, almost going to die, you must have a quality time with the relatives. That will definitely allay the anxiety and the fear and the apprehension. Listen carefully. This is a very important thing I have learned over the years. Careful listening to the parents is extremely important. Acknowledge their concerns and use empathetic statements, which has been told repeatedly. Example, I also hope child can go home. In this juncture, I would like to just to give an example. Then administration. In the beginning of our neonatal ICU journey, we had only two ventilators, bare cup ventilators. Then you got one more ventilator shifted Newport from adult ICU, which can be used for newborn also. But with the load, we are not able to manage. Sometimes we used to do some unethical things by quickly weaning off from ventilator when he was receiving ventilator treatment. So I went to the administration for some more ventilators. Repeated letters did not make any difference. Then the director told me, I will take you to the CEO. So one day he kept the appointment, we went to the CEO. I took 15 minutes to talk to him. with my emotions. I said to him, I'm doing a lot of injustice to the babies. I don't like to have any more cuss from these babies. Either we should continue with the NICU or we should stop it. He is a retired IAS officer, secretary to the government of Karnataka. I learned from him at that stage that he was careful. He allowed me to show my emotions. At the end of it, he just gave a small smile and he said, Dr. Maiyya, at least you have said like this. If I were to be in your stage, I would have trashed everybody and resigned and went off. And he also told me, within 24 hours, order will be placed in the next 2 weeks, you will get 2 ventilators. So I learned 2 things in this. One is carefully listening to the people, especially when they are angry, especially when they are showing their aggressiveness, and acknowledge their concerns. And lastly, use empathetic statements. Next is the doctor builds the emotional bridge. This is the duty of the doctor. We are doing all the possible things. He slowly prepares the mind of to the face to just to face any eventuality. When a patient is sinking with all your efforts, sometimes we have to go slowly and put it to their mind. Many times parents will not be in a mood to listen to us carefully. With all that explanation, final they will ask you, is he all right, doctor? We are given a very grave prognosis. Finally, they ask us, is he all right? How long will he take? So for this, it's an emotion which will not help them to accept what we say. So we have to walk over this emotional bridge. So for that, I would like to say that we are doing everything possible. We are only the healers. Next to the God. I mean, the God is the, he is a, that's what I would like to tell all of you, that you give the credit to the God, and next, your job is only to dress under his directions. Next important thing is the recording of the counseling whenever and wherever possible. Now I see majority of the institutions have got video conferencing and video recording. And documentation of the patient's file is mandatory. Dr. Kishore has already said, every change in the baby's condition or every change in the treatment should be recorded in the file or in the record. And everything should be available. At the end of it, many times patient asks for the medical reports. So we should be in a position to give black and white report. Death is death. What is special in child's death? Admission is generally a crisis to the family, especially in this particular season. There is a problem in getting an obstetrician, there is a problem in getting the pediatrician, getting a problem in the anesthetist, and there is a curfew. There's a lockdown, and you can't get out of the house. So the parents to take to a hospital is difficult. And from one hospital to another hospital he has to take. And you should have a police permission to commute. So with all that, the anxiety and the emotion definitely will increase the parents. Situation is like a lighted candle in a stormy weather. Parents are generally concerned about the lighted candle alive, especially as a male child is a torchbearer of the family. They would like to tell you that whatever is possible, please do it. We don't mind spending the money. But when it comes to the bill later on, the whole scenario changes. Death none. The most sensitive doctor, it was a tough one. Divulging the news to the relatives will be like a warrior who has lost the battle. I would like to say a few words about a case whom I had to handle. A baby who died at 3 a.m. in the night. Our doctors have explained to the patient, called them and told them. They said they will take the baby around 10 o'clock in the morning. So when I went there around 11 o'clock, still the body was there. I was trying to find out what had gone wrong. So within about 15 minutes, I saw a group of about 50 people walking into the NICU. So I had a call, I had to go back, and I was in my room after that talking to somebody. Within a few minutes, I got a call. Dr. So-and-so has disappeared because the crowd was more. Can I send the people to your room? I said, yes, don't send everybody, send only 2 representatives. When they came to me, I listened to their views. I learned that their problem was the bill. Those days that I had a lot of freedom to give a lot of concession, even lakhs of rupees. That was the beginning of our NICU. When I was talking to them, about 10 people rushed into the NICU, took the body and ran away. Then I knew what the problem is. Their problem is the bill. What I did to them, I said, stay here only, we'll try to help you. So I asked somebody to take the file to the billing section, made the bill, and bill was brought to me. I wrote nil to pay, so that the whole this problem was solved. Sometimes we may have to give importance to this type of thing, what they want. It's not all the time because they lost the baby, sometimes for the money what they have spent. Next is dilemma is how to divulge the news. When you have a problem with a baby and the baby dies later, every day you are telling one or the other things. Today we say the baby is better. By evening another doctor comes and says the baby has got some PD has opened up and has got one more problem. Next day another problem. He had developed sepsis. So every day one other problem we may have to divert, we may have to talk to them. So the dilemma is how to divulge the news toward the end. So I always say that though the baby is with us, your baby's problems, whole Bangalore knows. I got friends in Manipal Hospital, friends in St. John's Hospital, and friends in Fortis and so on. I said, I have consulted all the problems of your babies with them. They also say that what you are doing is fine, and you have taken their opinion. Whatever changes had to be made, we made it. And so a baby got the best possible treatment. Death space none. Depending upon the strength of the doctor and the patient, emotional bridge. Sometimes what happens is, doctor may be arrogant. Doctor do not want to ask more questions, more answers. And patient will be cool. Sometimes it's just opposite. Patient is very aggressive. Doctor is calm. But doctor can easily walk over the bridge and deliver the news in the mind of the parents. Tea-wasted parents. Most parents go through grief reaction. One is a denial, feeling that it cannot be true. They don't accept the death. Again, one more example. I had a baby. Not a baby, it's a child. It's not a newborn. You might have heard from the newspaper, some 3-4 years ago on an Independence Day, parents took a child to Lal Bagh show. The child had bee bites. some gundas, some boys had disturbed the bees. They bitten the child too much. There is no normal skin at all. So much bee stings. Father was also bitten. Mother was also bitten. They rushed to a hospital. Few hours later, I came to know that this child was admitted. When I went for rounds on an Independence Day, I saw the baby. The child was in shock. So you had to do everything possible for the shock. Started ventilating the child. I cannot shift the baby anywhere. The child was too bad. And noradrenaline drip, everything was given. Within few hours, the child died. The mother asked me, so far they were all right. They said everything is being done. I showed them the honest things. Toward the end, she asked me, could you have done something more? That's what I said in the previous slide. I had a discussion with our other neonatologists of the city. That is always better. I said, yes, I have discussed with another intensivist in Sagar Hospital. He said, nothing more can be done. Then she asked me a question in the end. Is there any antidote? I was confused. What antidote for bee sting? I took some time to understand what she was asking. No antidote. Again, I asked somebody else. They said there is no antidote. So sometimes we may have this type of problem. They deny, they don't accept what you say. Anger. Denial means many times the patients say, no, doctor, go ahead and ventilate. Continue ventilation for some more time. My child will definitely come out of the ventilator. Next is the anger. Anger toward the treating doctor or toward the guard. Despair. Feeling of helplessness. I can't do anything more than this. I am in trouble. I lost this child. The second child I am losing. Or the first child I am losing. Guilt, is it their fault? What have I done in my previous time? Did I do something wrong? And this is the penalty I am paying. This. Accept. Why abnormal behavior? It's a personality type. I showed in my first slide WHO's definition of health. Personality type. Degree of maturity. Again, it's important. When you are talking to a young techies, they're different than talking to a middle-aged or older person. Maturity is easy to walk over when you are talking to a mature person. Sense of vacuum in the mind. They came with their hands full. Now our hands are empty. There's a feeling that they have. Precious child, difficult to accept the death. Degree of attachment to the child. I used to say earlier, very short time, the baby was only a few hours old, they lost the baby. It's easy to accept it, but now I don't feel that. The degree now, it's a nuclear family, acceptance of a small family, and infertility rate is going up, and a very precious child, and they can afford a lot. So degree of attachment definitely goes up with this. Coping with the huge ICU bill is what I said earlier. Though we are counseled in the beginning itself, this will be the cost of the treatment. When the bill comes in terms of lakhs, the patients always make a lot of noise. Now let me see the doctor before and after this. Doctor could be especially an young intensivist, arrogant physician. This word, thanks Dr. Kishore, he has used this word, so I don't have problem in using this word again. Arrogant, when I mean this, that means he doesn't want to listen to the patient. He He wants to tell something and walk away. That is an arrogance. But when you are coming to this, we should be very humble. So after death, death shatters the arrogant world of doctor and helps him to become very humble. Humbleness is the greatest virtue of doctor. Parents are emotionally disturbed. They are obedient earlier. As I said earlier, you are next to God, giving the reins of the chariot to the doctor. After death, the parents question the authority, is what I said. Have you seen this type of problems earlier? Could you have managed this baby? Did you manage this type of babies earlier? All these questions come later. Efficiency of the doctor. This way sometimes we may have to say that we have been doing this job for so many years. We see a lot of impossible. That probably explains the efficiency. Capability of the doctor and carried away in any direction by the wind of despair. Can we prevent the parental aggression? Any ICU admission is potential for death. So what is important, what has already been emphasized, is the improvement in the communicative skills. This is very important. Parents are updated on day-to-day basis. Involve the multidisciplinary this approach in explaining to the parents. What does it mean? I remember when I talked to the parents about the death, when many disciplines are involved. I involved the obstetrician, I involved the neurologist, I involved the pediatric neurologist, in addition to my own team. So this team generally helps me in walking over and explain to the cause of the death in these periods. This definitely helps. Sometimes I used the referring doctors. I remember I called Dr. Nagbhushan once. His baby had some problems. And the parents were aggressive. I called him also. He was with me when you are talking to the parents. All these things definitely help. These are some of the clues to the youngsters. I feel that when you come across this type of problems, you may have to do all these things. It's only small things that I will give it to you as a tip. Involve the family physician or the pediatrician, as I said, and legal implication. As Dr. Kishore said, everything should be recorded. Now, everything should be recorded by video. And ICU visits by parents. This is something, in my experience, I thought that you must allow the parents, I'm sure that everybody is doing that now, the parents after our counseling to go to the baby and see the baby and let them see what is being done. Otherwise, they will question what is being done to my baby. So this is a very important thing. And in addition, I'll go to some more extent and saying I involve the close relatives. In my earlier slide, I showed you they don't have the skills to cope. I feel that you must use the family strength to help the parents. Take some of the important people of the family, show them also the baby, they'll also understand, and involve them also when you are talking to the parents. I said earlier, I dress the wound and God heals it. So you must, if possible, we have done everything. As I said, we have taken opinion from all specialties. We have taken opinion from the other leaders in the city. And though the baby is here, and the baby got all the benefits, so you must do a buffer role. Facilitator to abbreviate the emotions. In Vellore, I had seen this. When you had some people who are emotionally upset, we involve the religious department. We used to have a religious department and they take care of them. Every day they come and pray for the baby and they talk to the parents. And this is another way of helping this bereaved family and demonstrating the healthy way to cope with the death. Many a times, as I said earlier, it is not just this about they losing the baby. They require help in many respects. In our Ramaya Medical College, I had a very free hand. The administration trusted me, thanks to them. I used to uh, uh, give a concession as much of 2 lakhs, 3 lakhs, but the people never questioned me. That the real help I had when you had problems of the finances. But many times I feel that at least the doctors, especially the neonatologists, if not the hospital can't help them, we must always say, we will try to help you in reducing our bill, not for all, at least for some deserving patient, and also where we think that you are going to have problems with the parents. Parents' perspective on physician-parent communication. Again, I'll put it across to you. Physicians' availability. They expect the physicians available all the time and attentiveness to their informal needs. They may ask every now and then. They'll ask you your mobile number, but you have to give them or feed them every now and then, especially when the baby is very sick. Honesty and comprehensiveness of the information. This is again important. Honesty, I would emphasize again and again, honesty is very important, especially when you are dealing with a newborn baby's death. And withholding the facts or provision of false hope always gives you trouble. Contradictory information. In this regard, I would like to tell you that only one should be the spokesperson, like the political people. They have a spokesperson. Only the spokesperson will talk to the parents. In his absence, next in command will talk to the patient. But no nurse, no other doctors or junior doctors should talk to the parents. Parents' perspective on physician-parent communication again. Physicians' availability, as I said, and many a times I feel that you are all totally human beings. We have some threshold. Sometimes when it comes beyond a threshold, when you are dealing with such types of problem, don't get irritated. With all your irritativeness, you must try to control it. And I always say, smile is the best medicine. You must always have a smile on your face. I would refer to you, Dr. Prashant Gowda. Probably you can see him afterwards. That type of smile sometimes is very important when you are talking to them in the initial stages of the baby stay. And physician's body language. This again, I said, the youngsters talking to the parents and a mature person or a patient or a person with some experience is always different. When you are talking to the patient, especially when they are aggressive, as far as possible, senior most persons talk to the parents. Death, an unexpected death in the neonatal ward. This is a very important thing. Again, I'll give an example. A few years ago, I went to the ward around 7:30 a.m. I saw the baby nicely feeding. All parameters are nice. And the baby was the mother only. Father was also there, talked to them and came to the outpatient. Within half an hour, I got a call that baby is almost stopped. We are taken to the ICU. Rushed to the ICU, saw the baby had only heart sounds. We were intubated. Everything was done to the parents. This is a very important situation. And I feel that only a senior and experienced doctor should take over the situation. Even if you are not involved in the management of the patient. Be humble and be sympathetic. Very important. Be honest in saying what you don't know. Yes, I said I don't know what exactly happened. I can only list the causes, what can happen. It's a sudden unexpected the death in an ICU or in an infancy is a well-known topic in the early stages of my this neonatal career. But now we don't say that because there are many causes are there. I know that the fatty oxidation defects can also cause the sudden death in an infancy. So be honest in saying, and postmortem, such as postmortem, to confirm the diagnosis. I feel that whichever unit has got a higher degree of postmortem, generally they're doing very well. There are a lot of things to learn from the postmortem findings. Withdrawal of support, again, another experience. There was these are my initial days of ventilation of the newborn babies. It's a baby who had almost 2 weeks old at that time, premature baby, and experienced all the problems. A hyaline membrane disease, received Cervanta, and he had a PDA. We closed the PDA with endomycin those days. And the baby had sepsis. And our final problem was we were not able to wean the baby off. It's almost 2 weeks. And nutrition, we didn't have parental hyperalimentation. Nutrition was the problem. So the baby was, weight had dropped significantly. At that stage, I talked to the father again. Father, he comes from a very poor family. He's a rag picker. His per day income is only 15 rupees. He spent money for 15,000 as an advance, and he has paid for Cervanta. He cannot afford anymore. And I talked to him, say, if you ask me as a friend or your father, I can only say, withdraw the baby from ventilator support. When I went inside the NICU, one of my junior most colleagues told me, I told him what happened outside. He told me, are you doing ethical thing? I didn't lose my patience. I said, yes, I'll talk to you after some time. What is ethics when you are managing a ventilatory supported baby? So this is an example. Spend some quality time with the parents. Explain them both the short-term and long-term prognosis. Help them in taking decisions. And parents should not have the guilt, feel, or killing the child. Aftermath of death, hostility toward the doctor, hospital, and God. It's very rare to see the same babies going to the same hospital for the next delivery. I used to see this in Vellore because continuity with the parents, talk to them, the right to them. When the next pregnancy occurs, they always come to develop people again. So this is a continuation. Violence against close ones or self-blame, unconcern about the surroundings, pessimistic attitude, and slow acceptance to death. I'll go a little faster. I'm sure that I'm exceeding time. Our role is to assist the nature in healing the wound, to prevent the onset of uncomplicated grief reaction, to prevent the onset of psychosomatic disorders, prevent suicide, addictions, etc., prevent psychiatric disorders in their siblings. Follow up to detect complications. As I said earlier in the last slide, future pregnancy is important in the counseling, genetic, psychiatric reference if needed. Spiritual needs of the parents is a very important thing. Bereaved parents have intense spiritual needs. Healthcare provider can help the spiritual needs by words and actions that demonstrate caring presence and impart truth. By providing opportunity to stay connected with the child at the time of death, creating memories that will bring comfort in the future. What parents want? Parents want a physician to be accessible. Take all these tips, especially for junior doctors. Provide honest and complete information with caring effect. Use lay language, which is comprehensive. Withholding prognostic information from parents often leads to false hopes and feeling of anger, betrayal, and distrust. Again, a small example. We had a baby with all the problems of still they wanted to spend money and we stayed the baby. After 6 months, the grandmother rushed to my outpatient and blasted me in front of all. They went to Neonatal in Chennai for stage 4 ROP and they explained everything. So I had to get them the file and show them their signature. So you have to explain in detail. To summarize, death is a crisis which should be tackled artfully, intelligently, and scientifically by every clinician. Refining the skills not only help the others, but also help the doctor. Also, because the death is universal equalizer. More the humble you are, more easy for you to walk over this crisis. Can there be an ideal ICU and intensivist? Should I that psychiatric and counseling training? Should the parents be allowed to near the parents, near the patient? And what should be an ideal architecture of ICU? I feel that there should be some glass to show the babies so that all the relatives can see the baby, what is happening to the just to their baby. And organ donation should be the last thing which we should talk to them. Let us discuss, dispel our ignorance and helps us to be an ideal doctor. Thank you very much. I am sure that I have taken a little longer time and probably we can still continue. Thank you.
Yes, sir. It's indeed a wonderful presentation, sir. We know that this is not written in any books. It comes out of experience. And we are so grateful that you shared your life career experience, your years of experience. Most of the doctors we are here, it's our age actually, so it is matching our age. So thank you very much for sharing such a wonderful tips and tricks for all of us. So we quickly move into the discussion, sir. So there are questions. We are running out of time, but there are questions. First thing is, if parents are taking, this is to Kishore Kumar sir. Sir, are you there? Baliga sir, Kishore Kumar sir?
Yeah, I'm here.
So this is for you, sir. If parents are taking time to decide on treatment, the requirement of ventilation and other improvisation in treatment, and if something goes wrong during that time, by documenting it, will it save the doctors or institution, or what we should do, sir?
See, as far as possible as a clinician, you should do whatever is required to save the child's life. If the child is critical, you go ahead with the treatment. If they refuse, then you document and then you can do a DAMA. But just because they're refusing at a critical stage, if you don't treat, you become part of the homicide according to the legal medicine. So clinically, if a baby is dying, you have no right to withhold the treatment. As a clinician, you have to do what is right for the baby.
There is a few more questions, which you, Maiyya sir or Baliga sir, you can
Prashant?
answer. Yes, sir. Yes, sir.
Yeah. See, basically, that's what I said. You anticipate, and probably you should prepare the parents for ventilation much before. You see, and that would be the next step. And when you know that there are chances that in the next 5 to 6 hours, the baby is may go in for ventilation, preparing the parents ahead of that. That's what I said, being ahead of the disease. I think that should be the approach rather than, blaming the parents. You can't say, now the baby is collapsed, we want to ventilate, give permission. See, it's a terrible shock for the parents, right? So it should be prepared and anticipate and then get to, convince them beforehand.
There
That's
was
the ideal approach.
one more question. So this actually happened even with us in our motherhood hospital, Sajapur. One of the gynecologists told it was a 24-weeker baby. She counseled them saying that chances of survival, long-term complication of baby might be a problem. And mother had cervical incompetence.
Hello?
Yeah, I think this happens quite frequently, Prashant, in most of us clinical practice. 24 to 28 weeks, we have spoken to almost 10 legal experts, and everybody agrees that very gray area in the legal medicine, not in the clinical medicine.
My question is,
it's very clear that we can do, but legally, 24 to 28 weeks in India is a gray area from the legal point of view. So I think extensive counseling and whatever happens, you have to document and get the signature. Parents have a right to refuse treatment for less than 28 weeks because viability according to Indian law is defined as 28 weeks. So if they refuse treatment, if the baby happens to be a girl, you have to be doubly careful because you don't want to be part of the female infanticide according to the decision. So it is a very, very gray area. You should involve your legal team. You should involve senior people like Dr. Baliga in such situations and take their opinion. And whatever happens, document it. Because there's no clear-cut guidelines. And legal medicine and clinical medicine are different. So you have to follow as much of a safety net as possible. Baliga, you want to add?
No, you have given a very clear decision. That's it.
Here what happened was the baby did not even require ventilator. Baby survived. Baby was on full feeds within 7 to 10 days, went home. So they put a complaint saying that, why gynecologist counseled like this. So they started writing in social media. So the question, the similar question what is asked is, in case if baby survives and does well, we counsel them, and then if they start doing well, and if they put a legal thing, how we can protect ourselves. They had a recording. Sir.
See, Prashant,
Yes, sir.
Prashant,
Sir.
in that case, you see, basically this is what I said. Judging a situation is different from being judgmental. Now, judging a situation is, I'll analyze and then I will not come to a conclusion. Then give the possibilities to the parents and allow the parents to take a decision. But judgmental is you have made an opinion and that's the end of it. Now, if in that case, if you say the 28-week survival chances are not there, you can't go ahead. Now that's, we are giving the opinion. No, probably, survival, these could be the problems. The options are two. You can go ahead, give a chance, or you can leave it. You decide. So the decision here is a shared decision. You inform, and you inform the consequences. The parent will take a decision. If they had approached, if the obstetrician had put it across in this way, instead of being judgmental that the baby will not survive, I think things could have been avoided.
I think this has answered one more question, that can neonatologists give a hint to the parents about a baby who is extremely sick and chances of their survival is almost bleak or negligible, to not to proceed with advanced progression of treatment? So any of you can answer, sir. So what they're asking is, can neonatologist give a hint to the parents about baby may not make up, or or baby may not survive. Even if they survive, they might have issues, long-term issues. So can they give hint of withdrawal of support? That is what they meant, sir, in the question.
There are two aspects of this question, Prashant. One is withdrawal of
parents.
support is not legal
Kishore?
in India, and it doesn't matter what age it is. Second thing is withdrawal of support, especially if it's a girl baby, you have to be extra careful because that will be considered as female infanticide by somebody. Withdrawal of support is not legal in India, even if it's opinions from any legal aspects. So, on paper, it should never be documented, and even if it is done, I think it needs to be out of the documentation because that's not allowed. I look forward to either Baliga or Maiyya to say a few words.
Yes, sir.
I personally feel that, there are a lot of emotions involved in that. Whatever you say, it will only be at the subconscious level. They may not even register properly. Probably you may have to spend a little more time, especially when you are talking about the prognosis.
Yeah. Now, there are two issues here.
Yeah.
Sir.
Please, sir.
Yeah, my thinking is, guys, still remember, when a child with this type of problem, they are not too sick, we have done everything possible to survive this child. But after 5-6 years, they found that the child was very poor in the scholastics. They had been here and there. They attributed the problem to the neonatal problems. Then they came back to me. Haven't you explained to me all these things? That's why I'm saying that whatever they listen at that stage with all that emotions, it may only be at subconscious level. Probably you may have to take some more time or give some more time for them to think, to take a decision whether to continue the treatment or not. Dr. Baliga.
Yeah. See, here there are two issues. One is legal, the other one is ethical. Ethically, you cannot withdraw the support. So you need to continue till the baby is alive. Legal issues is that, it is that documentation, how we have taken the decision, whether we have informed subsequent consequences, and then maybe you can advise DNR, do not resuscitate. See, that is exactly what I said. Then you'll have to talk to the people, talk to the unit, talk to the other doctors, ask for second opinion, document a second opinion, follow the entire process so that you safeguard yourself legally also. And then allow that child the decision. See, here again the economic comes. See, you may have to keep the baby for next 2 or 3 days. Then the cost of bill. What is to be done, whether they can afford. See, these are all the issues which needs to be discussed. You put forth all the facts to the parents and allow the parents to take a decision. You facilitate the decision-making process, but you do not decide. See, and then you go in a very, very ethical way. I think that should be, and you can straight away tell them, see, look, I cannot stop ventilation. I cannot stop treatment. But if you decide and tell so, then definitely after documentation, I can do that. So that's how one has to proceed. You have to look at both ethical angle as well as legal angle, and safeguard all your interests.
Prashant, we can't hear you.
Yeah, he has disappeared.
You're muted.
Hello, can you hear me now, sir?
Yeah.
Sir, one more question which has come in Facebook. Suppose a baby is delivered at 30 weeks. Baby is absolutely fine, requiring some amount of respiratory support. But they have been counseled by their relatives or their friends regarding the survival and long-term complication. And they plan to take the baby directly home. Baby would require some sort of support initial 2 to 3 days, but they want to get discharged. Do the parents have rights in India to take the baby home and do whatever they want?
And the answer is, Prashant, unfortunately, the answer is yes. And what you have to counsel them and document extensively is, lot of the parents think that once they take the baby will die immediately. You should tell them that baby may not die immediately. And when those things happen, you try to reassure them and keep the baby. But if they ultimately refuse, involve your legal team and do a discharge against medical advice. That is most important. And you have to get their signature on the paper. That is the legal way of doing. Ethically, that's not correct. Morally, you know that this baby at 30 weeks is going to do extremely well. So it's a balance of all the emotions. So it is a very difficult situation, but ultimately the situation in India is parents have the right to take the decision regarding their baby. So you have to balance ethical, moral, and legal guidelines, but make sure that you document discharge against medical advice. Dr. Baliga, maybe you can add.
No, I think that's the right thing to do.
Yeah, probably I would.
Maybe other aspect is, to take the judicial way.
Because this caution came because of that Delhi incident, sir, 28-weeker, which survived and then died later.
No.
Became a national news.
Delhi incident was, there were two issues. Nobody is at fault here. Number one, less than 24 weeks is not viable according to any part of the world.
Yeah, any developed countries also.
Yeah. The other issue is you can't package a baby with a heart rate and give it as a dead baby. That was a mistake done by whatever the things is. If a baby has a heart rate, wait till the heart rate stops. So when you have a baby with a heart rate and you package and say this is a dead baby or fetus, I mean that comes into problems. That's why it was blown out of the proportions. So I think it's a lesson learned for a lot of people there. And unfortunately, though it's not viable, ethically, as I said, there are three issues here: ethical, moral, and legal. Ethically, morally, that was wrong. Legally, he was right. So you have to balance all the three to have a good outcome. Otherwise, that's what happens, and you land up in problems. And it's nobody's fault. It is nobody's fault that it happens, and that's why IAP, NNF tried their best to help, and they couldn't do anything.
Dr. Prashant, I feel that 30-weeker, as Dr. Kishore said, it's a lot. Baby, they're misinformed about the prognosis. I think we must put all the efforts for them to stay and take the treatment. Probably we may have to involve more people and some literature and show them your own experiences. Probably we may stop taking the baby away. And we can always say, when such a thing happens, when you see more and more complication, we ourselves will tell you not to do it. I think some sort of soothing things may help them to stay on.
So there is one more question related to COVID-19. ROP is difficult to be done in COVID season. How to proceed and how to legally safeguard the hospital and the doctor? And what is the protocol which is followed in your setup, sir?
I think Anand Vinekar gave a beautiful lecture in the NNF group last week, and he has circulated the guidelines. Maybe you can post that guidelines to everybody.
Sure, sir.
For those of people who don't know, Anand Vinekar is an ophthalmologist, pediatric
Baliga, sir,
who has done extensive work and he currently works in Narayan Netralaya. He gave a beautiful lecture, and he has formed the guidelines specifically for COVID season. And I think Perinatology can circulate that.
Yes, sir. Yes, sir. It is there in Facebook and YouTube as well. Plus, we will forward the guidelines which has sent it to us. Sir, it's a rare amalgamation of all of you, sir, with such rich of experience of different directions. So before we close the session, I would request Maiyya sir, Baliga sir, and Kishore sir, as an aspiring young neonatologist, to what you would give a tips and what you would suggest or advise or guide as your kids, as you look forward through us. What do you expect, or what you would want us to think about or go in which direction, sir? So we'll start with Maiyya sir.
I think I have given a lot of child. I think the probably the neonatologists of the current generation, they are much better than the earlier ones. I feel that they have decided to take up the neonatology, and what neonatology is, they also know about it. Hard work involved also, they know about it. I think you must go ahead with all that, and probably have. I say that do your job and take care of your family also.
Okay, sir. Kishore sir, during this time, what you would suggest, because as a practicing neonatologist, how we should do and how we should go about during this pandemic time? Legally, we are safe and healthy, so that we don't get the infection, we don't legally get into trouble in our practice. What you would suggest, sir?
Yeah. Look, as a neonatology, because it's a intensive care, we are talking about neonatology involving babies less than 30 weeks or 28 weeks or whatever you want to call. The real neonatology bread and butter takes a lot of years of experience. Just doing a fellowship for 1 year or doing DM for 3 years is not going to teach you all aspects of neonatology. So my sincere request, take it with a pinch of salt. Don't put masala into it. But what I'm saying is you need a good mentor at least for the 10 years before you can actually say you are on your own. Make sure everybody who is junior has a good mentor, and always use a phone or some other way of communicating, and have a good mentor in your life and take advice. Don't hesitate to speak to your colleagues, and that's the best you can do. Because if you are alone and you try to do everything on your own, you can land up in trouble without maturity. So that's my sincere advice. That's what I still have mentors. I still look up to people who can guide us in difficult situations. I'm sure mentors will add a lot of value and experience and wisdom. Thank you.
Sir Baliga sir, you have a huge fan followers across India and even outside India. So same is true for Kishore sir and Maiyya sir. So what you would suggest, because you have always been a guiding force and you have always enlightened us with your wisdom, with your experience, what you would suggest our upcoming doctors, sir?
Yeah, not only upcoming doctors, for all the doctors and neonatologists. So for the neonatologists, probably always remember that you're not born to take care of all the babies born in your place. So do what you can within your limits. Don't forget to lead your life. Balance your life. You have your family, your personal life. Take care of your health. And the best way to move forwards is to promote group practice, and thereby have a good understanding. Draw a line between need and greed. When you form a group, have a good financial understanding, follow transparency. I think then the conflicts will be much less. That would go a long way in enjoying profession, achieving professional satisfaction, and having personal life too. I think that should be the way. In the process of chasing the profession, I think most of the people spoil their life. It's the saying goes, the doctor dies to make money, and when he makes money, he dies. I think that shouldn't be the situation.
So we have our President Kotreshi sir. with your experience, what you would add few. Sir, are you able to hear us, sir? Kotrishi sir, are you there?
Can you hear me?
Yes,
Hello.
sir. Yes,
Can you
sir.
hear?
Yeah, yeah.
This is a very good very good topic today. Experience and Dr. Baliga and Dr. Kishore, especially Dr. Maiyya, who is very senior to all, and we could be opportunity to hear their what is the ethics of practice. Just now Baliga said regarding the how the professor should be there, not counts on money, only counts on service. Even Kishore said a lot of experience of